Hey guys, welcome back to another episode of the AltMed podcast. Andrew Dowling here with me as always, Mitch Kurtz. How you doing, Mitch?
Oh, good,
Yeah,
mate. How are you?
I'm well. I'm well, although I'm not looking as tanned or relaxed as our guest, who is a repeat guest. We loved having her on the first time, and she's back to do it all again. It's Dr. Zaina from Double Bay Doctors. Zaina, how are you? You're looking just like
I'm
incredible.
I'm fabulous. I had a great summer. Thanks for having me, gentlemen. Always a pleasure. I love banging heads about cannabis with you.
Yeah, likewise. What out of interest, so you were just saying before we jumped on that you've been in Thailand for a couple of weeks. I've never
Yeah.
really thought about this, but with your kind of doctor's workload, do you have to give all your patients like a big heads up before you leave, just so that there's no, okay,
I
yeah,
typically do, and I kind of make sure most of my cannabis patients have at least 3 to 6 months worth of scripts anyway,
yeah,
just so they're not stuck. But yeah, so everybody knows, and I think they managed pretty well. It was kind of 12 days, so everything was pretty under control.
no, very good.
Were they did you alert them to the fact that you were just doing market research or like what did you
It's not so much market research because it's kind of different what they've got there, but it always helps, doesn't it? I mean,
Yeah,
as a physician, if you kind of try out different strains, you've got a bit of an idea. Amsterdam, I prefer, but
yeah,
not
no,
to
Yeah,
July.
I found when I went to Thailand, it was very interesting. I didn't find the quality to be there at this moment in time. It seems like you can get away with very high priced products, next to go-go bars and all that. It's just kind of the transient tourist crowd will pay whatever because they're in town for 3 to 7 days. You know what I mean? So, yeah, I wasn't enamored with what was on offer there, but it is interesting to see it in that light, especially coming from where we come from, if you know what I mean.
and aren't they? They're
I
going
agree
back to
entirely.
medical. Is Thailand going medical?
Yeah. So I think a few weeks after I was going to leave, they were going to shut down the recreational business, which is probably going to be devastating. I mean, there's a lot of poverty and a lot of these communities, like where I was down in the south, every, kilometer, there's a new cannabis shop. And I don't know. I think it's just not going to be really good for the community for them to shut that down. And I don't know how they're going to really create a medical market there that
Hmm.
that will be as
It's
financially
also
providing the same trickle down kind of economics to people.
Yeah.
it kind of also strikes me as very difficult to um go back on in a way. Like I think that when once you've unveiled that, it feels like the social shift would have already occurred and people just not really take it that seriously in a sense.
I agree.
It's probably like trying to claw back guns from Americans. I know we did it in Australia, but
Yeah,
it's
yeah,
something like that. You know what I mean?
yeah, totally. Prohibition.
Anyway,
Yeah.
I
So
think
what's yeah, I'll let you lead this one, Mitch.
this week we did have the idea of talking about dosing formats. That was definitely
Mm.
something that we wanted to touch base because it's something that we've been, well, when I say we, I really mean you've been dabbling with in your practice,
Yeah.
and the idea of blending and different products and how they might interact together and that kind of thing. So, um, it's a very broad topic, but what are you kind of what's on the train at the moment? What do you seem to be reaching for in your clinical kind of
I
practice?
Yeah, look, I think it's so individualized and it didn't used to be a few years ago when I started practicing, but I think the deeper you kind of get into it, the more you understand the nuances. So it really depends. It's more by kind of patient group. My practice is extremely varied at the moment, Mitch. I think all my patients kind of have a different thing happening. But the reason I wanted to talk about dosing was I was trying to organize a script through DVA. So for people who don't know, DVA is the government body. It's kind of like the Medicare for returned veterans, and a lot of them have physical injuries and wounds, gunshots, etc., shoulders that have been worn out from carrying their kit, fractures, and of course, PTSD and insomnia. And so because of after a medical discharge from the military, there's costs for living, trying to retrain into a different field if that's possible with their injuries, but then also, you need money, right? Just for this treatment. And we know cannabis can be more expensive than the traditional opioids and things because it's not covered by Medicare. But DVA will cover some of these treatments. The process is difficult for GPs to work through, and I have to admit I would just say no and not do it for a while, but I'm trying to kind of take that on a little bit more for patients. And that's really where I felt like, okay, we need to talk about dosing, because I think a lot of people don't understand it that well. For example, with the DVA, they have different dosing tiers, and the way the pharmacist calculates it is based on the weight of the flower. Now, we know if you put 0.1 grams into your vaporizer, and we'll go through this properly, but if you put 0.1 grams in your vaporizer and you take one inhalation, that's a different dose to you taking 3. But when they put the restrictions about how much they will pay for the patient, they do it based on the weight of the flower that we put into the vaporizer. So it's important for prescribers to know that, for example, to coordinate, this is probably a tutorial more aimed at doctors, so I won't go into details there, but there's a lot that has to be considered in terms of like how you are prescribing one of those scripts. Otherwise, the patient has to come back to you every 2 weeks or 4 weeks. They can only get a certain dose, and it's just, they're wasting flour, it's expensive. So anyway, that's why I wanted to kind of talk about this, and I'll let you ask the questions that you think are useful for your audience.
Well, can I just, before we jump into dosing, I just wanted to ask about that whole DVA thing, because it's something that comes up a little bit. And to the best of my knowledge, it's not like it's a process that's not really, and you were kind of touching on this, but I'm hearing from different sources it's near impossible to get a level of support for cannabis medicine if you're a returned serviceman or women. And what's your, is it just kind of not worth it as a doctor because of the paperwork and the effort that's involved in it?
It depends. I think it depends on how supported you are in your practice. But the problem with this type of thing is you have to be on the phone and do all of it. I did it for a patient previously. And so there's 2 aspects to this. And my advice to GPs would be very careful in understanding your remuneration. One aspect is being paid for the consultation. Okay. So some insurance companies will say, we'll pay for the patient's consultation, or patients will be told by DVA they can claim it back. That is extremely difficult. I had a patient who was basically lost to follow-up. He had racked up. I just was not charging him because we were just waiting for DVA to approve it. And then he disappeared and owed the clinic, like $1,500, or me directly that. So what I do now is we're a private clinic at Double Bay. I'm one of the GPs there. So we just charge a normal private consult. But the bit that gets supported for the patient is the cost of the cannabis. So they're only out of pocket like $65, a few times a year when they come and see me, and stable patients. I just see my stable patients 6 monthly. Unstable, we might see, between 2 and 3 months. So that aspect is very affordable. Once a year, you're doing a $65 gap. But the thing with DVA is you have to sit with the doctor and like calculate your dose, and then you have to write it on an old school script. So we use Medical Director, and because cannabis is not it's not a medication that has an authority number, the doctor has to then have a handwritten, like one of those old school scripts. So I had to get I had to send the patient away. My practice manager had to order one in. I had to write this, and then you have to post it or take it to the pharmacy. And then I was on the phone for literally 1 hour, which in the middle of a GP day is crazy. And then my practice manager chased up, and luckily I've got the resources. But eventually we got the approval done for, 1 month worth of product for him. So they will pay for, they won't allow, I shouldn't go into it right now, but basically they will only give you 3 months worth of supply. Okay. But you need to be using less than, 40 milligrams per day. So if you've got chronic pain, shattered ankles and PTSD, you can get 3 months, but you need to be having I couldn't even prescribe 0.2 grams, which is the dosing capsule, right? Without going to tier 2. which means then that's a whole other application. So for this patient, I had to give him 1 month, and then I'll have to see him again and do a tier 2 application, which is more involved. So I think the first few appointments are a bit difficult, but I agree it needs to be streamlined. Maybe something for MSLs to look at.
Honestly, I'm sort of just hearing through all of that, yeah, it's just a treacherous process, totally not worth it for a doctor or for the patient, really. And probably the best thing that's happened to, returned soldiers who, require medical cannabis is just the fact that, there's some companies that offer concessions and those sorts of things. And also just the price of flower generally has come down quite a bit. There's a lot more in that budget range. But yeah, that is outrageous.
I agree.
40 milligrams a day tops. I mean, geez.
Yeah. So the interesting thing to note is that's the DVA requirement. So I'm an authorized prescriber, and so NIM and so our regulatory bodies, for your listeners, that regulate cannabis authorized prescribers and maintain standards, they say 500 milligrams per day.
Right.
But the DVA's got 40. Do you see? Because they see that 40 is just, 0.2 grams, because this is the issue. They calculate it not based on the milligrams of THC. Because what I was saying is, well, the patient, we put this in to allow for it to, for convenience of weight, etc. But the patient may only take 1 or 2 inhalations, but they don't do a calculation based on that.
I feel just in the background of our conversation, I'm just going to draft a sternly worded email to the Department of Veteran Affairs just to let them know that they're full of shit.
I'm sure they'll take it on board.
Yeah, they will. Yeah.
Who sets these amounts? Like, who actually decides, oh, that's it? You know what I mean?
People
like,
with no idea.
Not me.
Yeah. It is interesting. What, out of curiosity, this is kind of...
Sorry, I have to correct myself. That is just for tier 1, which is the tier 1 is where it's easy for GPs to do. You get a new patient, you can call them up, you can do like an old school script. The tier 2 is more involved. So it's just...
I got to say, tier 1 sounds pretty challenging as it is. If that's the easy one, that is fine.
Yeah.
Tiers, as in tiers 1, I'd say. And this is probably a segue into dosing formats in terms of talking about dosing amounts. I've heard very different things depending on who you speak to about what the maximum dosage on flower is that is recommended, allowed, however you want to say. Most people I've heard talk about 60 grams a month. Some people say you can, if you're confident, you can say up to 120, 150. I've even heard for, special circumstances. Would love to get your thoughts on the matter, because we hear of all sorts of things happening out there.
Yeah. So I'll just start by saying it really depends what your patient demographic is. So I'm just going to not include palliative care, end of life patients, because whatever they need, they get, right? But talking about, and I see a huge range of patients, my rule of thumb is I give everyone who is stable and I'm happy with their treatment, I give them a 10-gram container. I put a 30-day interval on it, and I give them 2 repeats. Now, my logic behind that isn't because I expect them all to be using 0.3 a day. It's because if I'm away or there's a stock issue or, they lose it or whatever, it's only 30 days they need to wait. And I know they're having 0.3 of a gram roughly, and it's safe. My trigger point for someone who needs that interval shortened is I tell them, you need to come and see me. And we need to think about what is going on in your life that you need to have this kind of every day. And I certainly do have patients who require, higher doses, but we might have a plan. So we might say, okay, for 6 months, this is what we're doing, or for 12 months, this is what we're doing, and this is our step down. And the reason for that is, what are we optimizing for, right? So if we're trying to not kill the patient, that's a different question. You know what I mean? Like, so what are the high risks with what you said about the 150 milligrams? I don't have any patients on that dose who I've prescribed, but I do manage patients with mental illness who are, having multiple bong hits and doing that thing. Obviously, the main issue and the risk is psychosis and then dependency, but, we deal with more hardcore, dependency issues than cannabis. I think if you've hit a plateau and you can't get high anymore, your CB1 receptors have downgraded or involuted, and your brain's telling you need to stop. Okay. If you can't take a tolerance break at that point, or if you can't get high anymore, then something's wrong. Now, that doesn't answer your question. I can go on, but I also don't want to make this too boring. I think a rule of thumb is we have to be very precise about the symptom we're treating. Okay. So if I have a patient who has PTSD as well as insomnia, I will ask them to preference either a cannabis oil or another sleeping agent for sleep. And we will track and monitor if they have a device, their REM and their deep sleep, because that can be affected in some people. And then they will use their flower, and I just call it cannabis assisted therapy. And so they will, for example, set a worry time every day. They come home from work or they're really stressed. Now they're explosive and their PTSD is triggered for whatever reason. And they can sit down at 7 o'clock, vaporize 0.1 grams with their journal, self-therapize. And that way, at least we're rewiring their brain. Nerves that fire together, wire together. So it just depends on what the issue is. But I personally think 1 gram a day is a very high dose. I would not, if I would not be comfortable prescribing that to a patient as therapy. Okay. If a patient is dependent on cannabis, if a patient is has pancreatitis and trying to come off alcohol, or, trying to come off ice or heroin, or if they are, they should not be using 1 gram of vaporized THC. To give you an example, 1 gram of a 22% flower is 2,200 milligrams. I cannot prescribe that on my authority. My authority, sorry, 220 milligrams, correct. 220 milligrams, which if they are using it correctly, like through the day, I think that's enough for them. Anyway, I think if you're using 1 gram a day, your condition is not stable. And I would have a plan to get you down over the next 6 months. And look at what else is going on.
Because I actually remember speaking to someone late last year who was having 4 grams a day. And I was like, mate, and by the way, like, just gave the impression that he had all his faculties. And I said, are you medicated as we speak? He's like, yeah. I'm using regularly throughout the day. Yeah. And like, I just have extraordinary pain that I'm managing.
Yes.
And I was like, shit, because surely at that point, when you're that dependent, you want to take a break. But then I'm like, what's his options if he takes a break?
Yeah, exactly.
Ketamine, or like what?
Exactly.
Like, what do?
Great question. And I have a younger patient, completely dependent, had to admit her. No one would take the admission because no one will take someone with that kind of level of dependence for pain. But yes, ketamine infusions, etc., are an option. Let me go back to this 4 gram. Now, the thing is, it's just inefficient. Okay, your brain doesn't. So let's talk about the risks. There are studies that show, there's an association emerging with cognitive issues down the track. Okay, you get decline in your dopamine function, you get damage to the hippocampus, the working memory, right? So you get this kind of ADHD syndrome. It will damage your brain. Okay. But it won't, like, how much damage is enough to cause dementia? This is all, we're talking about genetics. We're talking about complicated things here. One of my patients chronically using, cannabis for years and years and years and years, in her 70s now, lung cancer. Was that an association? I don't know, right? So the 4 grams is way too high of vaporized THC. And it just shows that he's got a very high tolerance. So other agents should be used. A tolerance break can then lead to, a dropping his dose. But it sounds like he's not motivated. Okay.
Yeah. And I was also thinking, I'm like, if you're on, I asked about potencies, like, generally in that 25% THC flower he's on. And I was like, so that is actually 1 gram a day of, 1,000 meg a day of THC. That is obviously a lot. And I think I heard you say before that the parameters that the authorized prescriber scheme set are 500. So he's on double that. But I'm curious, I suppose doctors have a right to prescribe as they see fit in their clinical practice, would a doctor actually ever be reprimanded for having allowed that patient to be, because surely there has to also be, I'm trying to think of the sanctity of a doctor's right to prescribe as they see fit for their patient.
Yeah. Doctors do not have rights, okay? Doctors have responsibilities, patients have rights. Doctors are bound by ethics, right? So the first principle is obviously do no harm. Harm minimization comes into that. I cannot comment, and perhaps that's absolutely the right thing for the patient, but the patient needs to have autonomy, and they can't have that without being informed. So I tell my patients, it's going to drop your dopamine, going to drop your testosterone. There's some memory impairment. I don't know the long-term effects, but we're making a short-term decision, and we'll make the decision for maybe 12 weeks. And it might be that they're going through a divorce, or there's lots happening. Usually at 4 grams, they're rolling joints, like almost always.
Yeah.
They're not doing 0.1, 10 times, but they're not doing that 40 times a day. They're rolling joints.
Agree. And then also,
so if they're rolling joints, they should then be spinning it with CBD flower and not tobacco. And that can be their first plan to step them down. So,
that's a great suggestion.
It's about knowing what issue your patient has and holding them accountable and say, you've got a problem, I'm here, and we're going to do this together. This is not the best thing for your health, but it's what you need right now because your cup's not full enough and you just can't deal.
Yep.
So how does that play then into something like a vape, which we're talking about, a 1 mil cart, for example, that's on the market that has, say, 800 milligrams in it or 750 milligrams, something that's 75 to call it 90%. How do you feel about that dosing format as a method of administration, and how do you reconcile with the potency of that versus versus cannabis, because it's obviously a lot higher. It's like having 3 or 4 times the amount.
Yeah. Great question, Mitch. I struggle with that for a couple of reasons. One, I don't know about the risk of like endothelial injury. I know it's supposed to be safe. To be honest, I don't think vaporizing is going to be great for your lungs either. Lung function declines over time. We're just worsening that. And I cannot calculate the dose that they're getting because it depends on how their inhalation, how long they're holding. There's a lot of factors. My oldest patient on a vape pen is 95, and that's just because it's convenient and easy. So I never go to it first unless the patient doesn't want to spend a lot of money. Vaporized cannabis may not be the right choice for them. We're just testing, or there's some kind of issue in terms of administering it. Maybe there's issues at home or there's arthritis. I think it's fine, but you have to now not use dosing to titrate. You have to use clinical picture. So you basically just have to review them more frequently. And I would again set 1 gram to 20 or 30 days. And if they say they've got anxiety or they're getting too high, I think, I see patients who are doing 1 a week. And I just think it's problematic. It's kind of too easy. You need to give your brain an option to not reach for that, right? It's like carrying a hip flask around. Sure, it's medication, but I don't know.
How do you feel about some of the extracts that are hitting the markets recently, the stuff that you may or may not need a dab rig for?
Oh, you mean like the super concentrate? Yeah.
Like hash?
Or shatter
hash?
And hash has been around forever and being used. I mean more like maybe you're not even familiar with it, but shatter.
No, I'm not. I'm going to jump on and have a look. Which one are you talking about?
I'm not going to talk about specific products. I'll just talk about the
I'm
product
not familiar.
types.
Oh, 70,
diamonds.
70, yeah.
Yeah.
Oh god.
They're very high potency.
Yeah, like the stuff you get, in Tel Aviv and stuff. Hey, like what is the point? Like, what's the point? I don't understand the point of such a high THC. Like when I see that, it's like I'm like, what's going on with the patient? This is not the only drug we have.
Yeah.
That's, do you know what I mean? Like, this is one drug. So,
that is it. What you just said is like, for me, the crux of why I find it so interesting that we have this prevalence of cannabis clinics, because it really almost, we're talking about one medicine here, really. And of course, it comes in different formats. And, you know, whilst I have a personal view that I am very favorable towards those medicines, I think we do lose sight as a, you know, as a bit of an industry and of the fact that there are so many other tools at a doctor's disposal that can be deployed to assist a patient. So do you find, just out of interest, being an experienced authorized prescriber, you know, I guess maybe a percentage would be hard to extract, but how many patients of your clinic are you treating with medical cannabis?
Patients will specifically seek me out for it. So it's not that my regular patients. So I specialize in mental health, right? So a majority of and gut health, and I'm an integrative GP. So I do a lot of like complicated medicine stuff for people, you know, particularly to do with gut and, you know, migraines and things like that. So I mean, I do a lot of the patients at our clinic because I'm one of three and I'll prescribe up to category 5. I'm trying to, like, I have probably treated about 1,000 patients. I'm not sure how to answer that question, but I can't do a percentage.
No, that's fair enough.
Yeah.
Out of interest, just with your mental health, I've had quite a few people saying to me lately, and I don't know if it's what the factors are, but a lot of people are saying, you know, I'm just feeling flat at the moment. Could be what's going on in the world, seemingly in every corner. And maybe it's their work and stuff. But are you, you know, just so many people telling me I've started seeing a psychologist, or and I know there's a large prevalence of just generalized anxiety in our community.
Yeah.
Do you have any observations around that, and perhaps any tips that you give to your patients just to try and stay well during turbulent times?
I basically only see patients in turbulent times.
Yeah.
Look, we're in a very bad financial time. People are really struggling. And this is why, again, it's very important for us to prescribe cannabis responsibly. Like, what is that going to cost? You know, 4 grams a day.
Yeah.
You know, it's like $300 every 3 days. But you know, that sounds like someone who's dealing to me. But anyway,
I was going to
we'll
say,
put that aside. You know, there's
again,
something going on there.
I'm pretty sure I think I recall it was a home grow situation. So to be honest, if you're going through 4 grams a day, home grow is a sensible thing to do.
Yeah,
You're
totally
exposed to considerable legal risk.
Look, I think foundations first. Okay, if you feel like life is out of control, things are getting on top of you, you just have to remember you're an animal with a biology. Okay, and we often live in our heads. And then you get stuck in a circuit, and we need to realize we're animals and come back into your body. People need to learn how to create a sense of safety for themselves. And there's different kind of techniques and meditation and things they can do. But I would say sleep. You have to prioritize sleep. You have to prioritize your relationships. And just don't eat crap. Don't eat crap food. The kind of work I do is very involved. So we'll do herbal treatments for gut microbiome and SIBO optimization. We'll do NMN and NAD and stuff like that for mitochondrial dysfunction. And so we go into a lot of high level stuff, but the obvious things are you should be exercising twice a week where you're about to sweat, where you're going to throw up and you're exhausted. And you should be sleeping, 7 hours at least. And you should have a GP, and you should really look and try and find a GP you have a good relationship for, because I can't even count the number of times I've picked up and my colleagues have picked up a cancer that was just completely, the patient had no idea. Sometimes you just notice things, right? It's a pattern. So for example, last year I was noticing there was 4 patients of mine who I ended up doing just ultrasounds on their neck for because of the certain picture they presented with, and thyroid cancer, completely random detection. So I would encourage people to don't worry about your health. That job is for the health practitioner who you trust and you have a relationship with. You just need to worry about your sleep, your diet, your relationships, and turning up on time to your appointments. And
is there, that's really
question.
all very good advice. I know the one thing that I'm starting to see getting rolled out in America and here in Australia too is for those who are wealthy enough to afford it, I think there's like, you can basically do a full body MRI scan, costs about $3,000.
Yeah.
You know, people are telling me I'm just going to do this annually for the rest of my life. I had somebody tell me this recently and they're in their 20s. I'm like, okay, that sounds expensive. And I'm just curious, what do you think about those services as a doctor? Are you skeptical, or do you think if you can afford it, you should prioritize doing that?
I think what's more important than a whole body scan is the person who's going to interpret that and treat you, right? So I get the concept. I have a few patients, like I have a few patients who fly in from Beijing with their scan and did it and then fly out or whatever. So that is a total thing. Totally aware of that. I would say you need a good physician, because why are you going to be scanning like your elbow? It doesn't make sense. So you need to have an organ-based approach. So you need to, doing an MRI of the brain doesn't mean your brain is functionally okay.
Yeah.
Okay. And, you know, if there's no tumor, we're not going to operate. So I think you need to understand that you need to look after your brain. You need to look after your liver. These are all different imaging, different investigations. It's involved. It's more involved than just a scan. I think there is room for that type of medicine. I think it's expensive. It takes time. It's involved. And, you know, people do subscription models, and there's a few of these things that, you know, Mark Hyman and Peter Attia and stuff are kind of rolling out in the US. And I think that's a great part of the market, because I think when you have that happening, you kind of pull things along. I think we're actually practicing very old school medicine. You know, we're waiting for people to get a disease. The difficult patients are the ones who don't have a disease, but they're completely dysfunctional. And anyway, there's some really interesting work coming out about mitochondrial dysfunction, which is the energy centers in the cell and how that kind of links to disease. But my
really?
thought
So
on
is
the
in like a neuron, does like effectively neurons, your brain cells, they're looking at disease pathology that arises.
Not the brain cells. Every single cell in your body contains a little organelle called the mitochondria. Okay. And that is what produces not just the energy required for you to live, but also we think it's involved in producing neurotransmitters, you know, lots and lots of things. I was looking at a study yesterday that said that there is, in the pathophysiology of PTSD, mitochondrial dysfunction is associated. So the area of medicine we're moving into now is pre-disease. We're very good at telling you what disease you have, right? So we're kind of looking at pre-disease and, you know, longevity, because people are going to be living longer. So we have to keep them kind of healthier. I feel like I'm not answering any of your questions.
No, this today. I just love ripping with you,
We just
Zaina,
have to, like,
because it's
because
so
they're hard and I can't quite answer them specifically.
No, it's great to chat, because I think about you know, imagine one day going to the doctor and they're like, look, you're fine now. I mean, you know, you're a little bit disturbed in the head, but you're otherwise okay. But you're actually going to get bowel cancer in 5 years based on like that. That is a wild idea, and if that's the direction that medicine is going in at the moment, I find that truly fascinating, especially also when, to your point, you know, we've gotten very good at diagnosing and even managing for a really long time chronic conditions. But yeah, to be able to intercept and do the work up front to spot an incoming disease for one concern.
But we can do that, Andrew. We can do that. For example, you get a scope done, right? So you stratify your family risk, and then you get a scope done. If you have a polyp, you get it done 5 yearly, because we know you've got a risk of bowel cancer. Okay. There's certain things I do for all my 40-year-olds or my 50-year-olds, right? And it's like this population medicine, and we have to support Medicare, and we need to improve the quality of stuff. And we can go into how Medicare is funded and that later. But if you are willing to invest in your health and pay the money, we can do incredible things. We can put 20, 30 years onto someone's lifespan. I can't even tell you the number of times this has happened. Preventive medicine is the most important thing. You should see your GP every 3 months. And if you have symptoms, you should see a functional GP. Once you get told you don't have a disease, but you don't feel well, that is the complicated space that, you know, a lot of patients play in. And that's where you need to see A lot of people see naturopaths, and that's wonderful. And if your naturopath gets stuck, I would say you have to see a functional GP. I just want to talk about that because I get this a lot. I get a lot of patients who come in from their naturopath with a list of like 20 bloods they want done. And I say, look, this is what Medicare will allow and what's appropriate. And these are what you have to do that's not. So then they've spent like $500 on bloods, and other, $1,000 on gut tests, etc., and then like $500 on supplements and herbs, right? And then they will come and see me at that point. Because and that's, naturopaths are wonderful and amazing, and I work with lots of them, but I think the issue is that naturopaths have not been treated well by doctors, and they've not been included in the care team, and so it's very isolated, and so then they don't know what the doctor's thinking, and they go off and do things that cost thousands. But in fact, if there was a better line of communication and the naturopath said, this is what I'm worried about, the GP, I as a GP could say, actually, I did this 3 months ago. I don't see this as an issue. Let's put a pin in that, come back in 6 months. I want you to work on, for example, improving their microbiome and doing herbal treatment for Klebsiella. Do you know what I mean? But I think what's missing is, because GPs may not always have the time to do that, and they may not be remunerated to do that, right? As well. So
do you think we even have the resources, I guess at a population level, to be able to support every Australian seeing a GP every 3 months? Or is it,
that's what we fund for. That's what we fund for. That's kind of the average. But the problem is it's not good medicine, because people go in with like an issue and their GP needs to fix it. And to be honest, being a GP is a very hard job. And when you burn out, you're not doing it properly. And GPs, to be honest, make the least amount of any specialist, in Australia, and they save Medicare the most amount of money. So
they're almost the most useful, and
they're the most useful, literally, literally. Because if you have a good GP, you just need a few things done. It costs $1,000 to see a psychiatrist to get treated for ADHD. You know what I mean? Like, anything.
I mean, also the just the fact, and I think you touched on it before, but we fund Medicare through, and this one's to all taxpayers out there, the Medicare levy surcharge that gets slapped onto our tax every year. At this point, throughout my entire life, Medicare has seemingly been on its knees and always needs more funding. Do you, in your assessment as a doctor, do you think that surcharge is likely to increase at some point in the near future, just based on current demand?
Look, I think that's for politicians. I don't think it's the right answer to a complicated problem. It's like if you're carrying around a bucket, with a hole in it, the hole keeps growing, you just shoved a hose in there, now you're just walking around, you think you're very smart because it's taking twice as long to drain the bucket. The system is, look, as someone I've worked in Broken Hill, I've run rural hospitals, I've worked in bulk billing in Campbelltown, and then private practice in Double Bay. I've run my own, clinic. So I've seen this from multiple different points of view, and I honestly think that if I could get my hands on patients earlier to do the work, it would save us millions and millions and millions of dollars. Let me give you an example. So I was in Forbes running the emergency department there, and this is in the middle of COVID, right? First of all, it was crazy. I can't even believe that. Had a woman come in, respiratory illness, very overweight, and her son is like 5 years old, extremely overweight. This kid is going to cost Medicare millions of dollars. He's at risk of having heart failure at the age of 30. He's probably going to get diabetes. Who knows? Dialysis costs tens of thousands. All he needs is an intervention for him and his family to lose weight. There is zero funding for that. There is the 5 sessions GP management plan thing, but there's no effective program. The government should be running programs, and the government should be hiring doctors and putting them on a salary. The government should be saying, okay, you're going to get paid $400K a year. You're going to take care of these 3 rural towns. You're going to run this it's just no one is thinking.
That is such a, it's crazy that we think about that. You just said is such a revolutionary idea, but it makes complete sense to me as a very practical way to resolve it.
Totally.
I just wanted to chime in and say, so blending.
Okay.
Yeah, I know, right? I'm like, we've got a total tangent.
We love tangents on AltMed.
Yeah, no, we love
all right,
tangents.
we
Okay,
bringing it back.
should we start with vaporizers and then move into flower? And you don't want to talk about oils today?
Listen, I just want to come back. Look, I'm happy to go wherever it goes. I just want to keep it a little bit more in line with the kind of things we were chatting about in terms of blending. And I know it's a huge kind of, abrupt change from what we were chatting about just then, but I did want to get onto the topic of talking about blending and different, or potentially dosage formats, but then also looking at, minor cannabinoids, using things in conjunction with each other. I know you said how you kind of use oil and then you used flower on top of that. We obviously have vaporizers. We obviously have topical. We have, a few different things coming to the market, capsules. I want to get an insight into how you use them, how you use them both from a format perspective, how you use it. Say, would you explore a CBN oil? Would you explore, a vaporizer that just has CBG in it? I know there's one of those on the market. So it's just like, do you use compounded formulations to test out this stuff? We had Bonnie Goldstein on the podcast, and she was talking about how she does sometimes experiment with just giving a high dose of CBDV to see, based on the clinical literature that she's read, it could be appropriate for that patient, and she kind of uses them as a hamster with their buy-in, if that makes sense. Like, I'm interested in that kind of stuff.
So I think we had a brief chat about Bonnie, and I've got to watch more of her stuff, but look, absolute legend and gun, and my knowledge in terms of minor cannabinoids is nowhere at that level. For me, it's more like the whole patient and what's going on. So in terms of blending, the only reason I'm not doing minor cannabinoids is because it's just the cost, right? So if a patient was completely price insensitive, and I came across some, evidence that this is going to be much better than a whole plant, extract or whatever, then I would try it. I don't think there's any harm. I think that's a very patient-doctor contract, right? So the way I kind of approach it is, most patients need a toolkit. Okay, my patients know this. Most of them need a toolkit, which will consist of CBD products, THC products, hybrids. I have some very experienced patients who will come to me and ask for a specific product. And if it's safe for them, I have no issue with them trying it. So that's kind of answering your question. I will probably need to do more education. I'm waiting for more robust data showing that a particular product with whatever, cannabinoid is helpful. That said, I do love your CBD oil, and I know it's got a bunch of different cannabinoids, and I find
not talking about specific products.
Okay.
I think Mitch is worried about any perceived promotion of supply contrary to Section 42 of the Therapeutic Goods Act.
Oh, okay, cool, gotcha.
Is that what you were worried about, Mitch?
Yeah, Mitch, do you want to break?
Couldn't have said it better myself. Actually,
do you want to break the question up for me? Because otherwise, I'm just going to be talking in a long chunk. Do you want to ask about blending flowers or vaporizers, or do you want to break it up? I think that's better than me going on for long.
Sure. So I think the obvious one to chat about is how do you apply different products together to get an intended therapeutic outcome in a patient? How do you use an oil, a vape, a flower, a topical together, or suppository, I don't know, whatever it is, to kind of achieve an outcome more conceptually than a specific, I use this product and this product, but I might use, something topically on a skin condition and then also have it orally because the combination, blah, blah, blah.
Okay, so I guess the best way to explain it is probably through a few different cases. So I've had some patients who find that they're quite, that they've wanted to reduce their smoking, for example. Is that interesting? Should I talk about that? Like the smoking? Yeah, okay.
Sure, I mean, that's pretty common.
Yeah. So one population group that I think the blending works well with is the patients who come to you who are smoking like 4 or 5 joints a day, and they're spinning it with tobacco because they're trying to save their bud and they don't want to spend too much. And so I think in the first instance, switching them to giving them a CBD flower and a THC flower, asking them to purchase a vaporizer, recognizing that completely stopping smoking, within 7 days and switching to vaporizing only may or may not be realistic for that patient. So we develop a contract, and it might be a few weeks that they will give themselves to be able to save up and purchase the vaporizer and completely commit to stopping rolling joints and tobacco. So the way we normally would start that is we try and get rid of the tobacco first, right? Because that's another addiction that's going to make it harder to wean down. They would then purchase a vaporizer, and they would, when they vaporize the THC straight, but then if they feel like they need to smoke a joint, they would then, mix the CBD flower with the THC flower. So they're getting rid of the tobacco. They're reducing the amount of THC they're using based on a cost perspective. And they're also reducing the, functional amount of THC that they're using, but they're still able to smoke and wean down. So I find that quite effective is for current smokers to get them off tobacco. The other blending thing that I find quite good is for people who have insomnia, but then also have, pain or, anxiety that is responsive to THC. And what we try and do is if it's a longer term issue, you want to keep their tolerance down. So I'll blend oils and flower. And in that instance, for example, they might, when they come home, they might use, 0.3 mils at 6 o'clock. And then I actually find splitting the dose quite effective recently for some patients. So some patients, for example, for insomnia might use, 0.6 mils of a 10-10 oil. So 6 milligrams of THC, 6 milligrams of CBD at 7 o'clock, and then fall asleep by 9. But then for some patients, especially the ones who are very anxious, or like the executives of working, and they just need to be able to reduce the time for their nervous system to relax, those patients benefit from split dosing. Sometimes you can give them 2 oils. Sometimes just the 1 is fine. I do always try and use less products just to balance the cost if possible. So those patients might, for example, vaporize a low dose THC flower when they come home, so they can unwind quickly and be involved in the activities they need to do at home. And then they might dose an oil at 6 o'clock to extend that benefit of the relaxation and the stress management. And then they might dose 2 hours before bed, and using kind of that initial flower to regulate their autonomic nervous system and their stress response. And then the second flower, and then the second dose of the oil and the third dose of oil, I find that works really nice for patients who are just resistant. In the past, I found what I was doing years ago was giving them flower to vaporize, right before bed. And they would have like 20 or 30 milligrams of CBD oil under the tongue with the flower for neuroprotection and to mitigate any psychiatric effects, like to protect their brain. And I found with that, it was fine, but patients, their tolerance would go up more quickly than if they were using the flower for quick relief of pain and to dose quickly, and then kind of timing their oils. The more oils they use, so there's actually 2 populations of patients. One group of patients, if you add in an oil, their tolerance to flower seems to reduce. So they seem to get much more bang for their buck. There's a second group of patients, though, that when you give them a balanced oil or a THC oil, they do not get as high from their flower. And these are often the patients who are cannabis experienced. And so they don't like the oil because it just kind of, it affects their high, right?
Yeah.
So it's important whether you're treating a patient's like pain or anxiety, because sometimes getting high is therapeutic, right? Like patients in PTSD, they don't respond as well to the oil because it doesn't have the neuropsychiatric effects. They need to be like that state change, right? They need to be, it's a change in their consciousness they require. So those patients, if they also have sleep issues, I try and use the oil for sleep, or I'll put them on another agent, another medication like, lemborexant or something like that. See, for patients who just want to use THC flower and don't feel that the oil causes too much sedation for them, or they've got issues with activities, work or driving, then for them, they will have different types of flower. So they might have like a category 4 or 5, 22, 25% flower. They will also maybe have a CBD only flower. And if they want, they can have a combination, a blended flower. But if you've got a 22% and you've got a CBD, you can just mix it yourself, right? And kind of, that's essentially what you can create for yourself. And so with those patients, I just make sure they're taking CBD oil every day and that they're taking regular tolerance breaks, and that we're agreeing to no more than 10 grams over 30 days. Because if you're only using flower, you should only be using a little bit of it, and using CBD and having fish oil. And we need to kind of track your sleep, make sure your REM's not going off. But yeah, I'm comfortable with people, having about, 23 to, milligrams per day, which is like 0.1, for most conditions, that's totally fine.
I must admit, I always just feel better if I'm having some flower to have the CBD oil with it as well.
Yeah.
So as a general rule, I definitely much prefer that.
Yeah, it does. I know what you mean though, when it says it takes away the high to some degree. It's almost like Narcan for weed.
But also what I meant was, what I was talking about was if you put them on, for example, a 10-10 oil, right?
Yeah.
Then if they're using a THC oil every day, they may not get as high from the THC flower, right? Because the receptors, if the oils are still there, so the receptors are.
So
I agree with you with the CBD too.
I do think that a lot of people, obviously they're beating down their receptors with the THC and building up a tolerance. In saying that, I do hear that a lot of people will move from something that has a high dose, such as even vaporizing or high THC oil doses, and then get an effect from, say, a flower that is very terpy or high amount of cannaflavins that just has a totally different effect. And even people that use high doses of extracts and dabbing and all this kind of stuff to build up exceptional tolerances can have quite a different experience when they get that mix of terpenes and mix of cannaflavins and all the rest, and maybe different minors that they're not getting exposed to normally, and just kind of knocked about a bit by.
I agree. Experience. There was a flower I was using. I won't name it, but it was like something like 5% terpene profile. It's discontinued now. And it was just the most soporific, relaxed, like you couldn't use it in the day. So I had some patients using it as like a PRN for sleep because they just needed so much less of it. And that comes down to the terpenes. I completely agree.
Yeah. So I thought that was very interesting.
I'm conscious of time just because we know are you, by the way, are you going back to a big patient load this afternoon?
No, actually, I'm only working two days a week, so I'm semi-retired.
That's great.
I'll just be looking after my kids, I guess. So.
That's amazing. That's so good. Good. On that timetable, you could potentially relocate the clinic to Thailand, actually, but
that's an idea.
I love it. We love chatting because so many tangents and so much ground that we cover, and yet I feel like we'd keep talking to you for the next 10 hours.
Totally. Vaporizers, do you guys have you mentioned that for your listeners before?
You know what?
Patients always ask this question.
No, let's
which vaporizers?
Exactly. I think a lot of doctors initially, and myself included, just recommended the Mighty Medic because we were told that that's the only TGA approved one. I think that's just the first one that got approval like to the market.
Yep.
I actually had two of them. One I dropped and just broke instantly. And then the other one I lost, but they're just really, really hard to clean, I find. It's powerful. They're clunky. It's powerful. And it's good. But recently I've tried what have I got now? The Solo Airizer, which as like a busy mum, I find it so, have you tried that? I find it so easy.
I've seen it. I haven't tried it. I've tried the Urban Leaf Mini.
I didn't like that. Mine broke and just, it's not powerful.
Yeah, it's kind of a bit brick shaped as well. Like it's obviously smaller than the Mighty Medic, but no, we haven't, Mitch, unless my memory isn't serving me correctly, I don't think we had a bit of just a chat about vaporizers, which for what it's worth, I mean, I think
not in depth, no.
We can, by the way, we can discuss product names, Mitch, just to allay your concerns, because a vape device is not a scheduled medicine. It's still considered, though, by the TGA therapeutic good, but there's different rules around it than those which apply to talking about medical cannabis and being
that's good to know.
So so what was have you had patients also just come in and give you feedback around what they're really into?
Totally. That's why I got the Solo Airizer, because I've had some patients who've just bought like 5 and they've, patient feedback is the most important thing. The thing with the Mighty Medic is it's so expensive, and for that price tag, you really do have to be best in class. Whereas I think the one I've got now, the Solo Airizer, I think it's like $300. Plus it's a lot easier to clean just because of the design of it. And it's like kind of smaller. The battery is much better. I'm not having any issues with it. So
that is good to know.
I love the Mighty too, but I find it's hard to maintain, and mine actually broke.
And I take it at $300. Like as I said, I haven't used one yet, but you can adjust the temperature and everything, I assume.
Yeah, you can go up to 220, which you don't need to, but yeah.
Yeah, okay. And I'm pretty sure the other one that the manufacturer of the Mighty Medic stores in Bickle got another product in market that was
Volcano.
Yeah, it was the Volcano. That's it. And again, I think weirdly, I'm just trying to think of the social taboo around just blasting a bag and then ripping it on a tram or something like that.
It's not happening. No, it's like, no. It's like, I mean, the patients who have had it like it. I don't. I have direct experience with it, but I think it's probably the most kind of robust device. But it's just cannabis. Like, you don't need a $1,000 device unless you're palliative care and you're bed bound. You know what I mean?
I wouldn't normally throw you under the bus, Mitch, but I just have to quickly put out there for our listeners a fun fact that your very first time being introduced to cannabis by your granddad, of all people, was with the use of a Volcano device.
Wow, I love that.
Clearly medical. Clearly
we have to talk about that later. Yeah, we're gonna have to talk about that one later. So good to chat, guys. What a long chat we've had today, and sorry for digressing, but always fun to bang heads about things and try and change the world and Medicare and DBA.
We do it one conversation at a time, and it's always a pleasure, Zaina. So thank you for joining us again. And look, I would dare say that at some point we'll just have to do this all again.
Yeah, I'd love to.
Absolutely.
So great to catch up, guys. Thanks for having me.
Our pleasure.
Zaina.
And take care.
Speak soon.
See you guys.